Welcome to all. I am Dr. Vasant and today we will see on acute pulmonary embolism. So in our slide we are going to see about the recommendations and evidences. So you need to know the classes of recommendations. Class 1A is recommended and class 2, that is class 2A and class 2B. Class 2 is should be considered, class 2B is may be considered and class 3 it is not recommended. This is one line which you need to remember. Otherwise, class 1 is evidence or general agreement that a given treatment or procedure is beneficial, useful and effective. So, it is recommended or it's indicated. Class 2, there's conflicting evidence or a divergence of opinion about the usefulness or efficiency of a given treatment or procedure. So, class 2 is the weight of evidence is in favor of this particular procedure. So, it should be considered. Class 2B is usefulness or efficiency is less established. So, it may be considered. So, class 3 is evidence or general agreement that the given treatment or procedure is not useful, in some cases may be harmful, so it is actually not recommended. So, when you see it's class 1, it's recommended, class 2A should be considered, class 2B may be considered, class 3 not to consider, okay. These are the classes of recommendation. Level of evidences, when you say it's a level of evidence is A, that is data derived from multiple RCT, randomized clinical trials or a meta-analysis, which has a very strong level of evidence. A level of evidence B is data derived from single randomized clinical trial or a large non-randomized studies. It's a moderate level of evidence. Level of evidence C is it's a consensus from the opinion of experts or a small studies or retrospective studies or some registry analysis. So, a weak evidence, okay. With this, let's go on to pulmonary embolism. So, what is actually pulmonary embolism? There is a block in the pulmonary artery. So, in this presentation, we will take that block as a clot, okay. When there is a clot in the pulmonary artery, what does actually happen? So, consider this is your heart, okay. So, you have the right atrium and right ventricle and left atrium and left ventricle, right. So, the pulmonary artery originates from your right ventricle. So, when there is a block either in the main pulmonary artery or its branches, the pressure in the pulmonary artery increases, right. The pressure in the pulmonary artery increases. So, this reflex pressure causes increase in pressure in the right ventricle also. So, when there is increased pressure in the right ventricle goes for dilatation, right. When the right ventricle goes for dilatation, lot of neurohumoral hormones gets activated. So, causing increased ionotrophy and chromatrophy of that particular right ventricle and left ventricle. So, the work of movement in the right ventricle increases, causing increased oxygen demand. Moreover, when the pressure in the right ventricle increases, this septum between the right ventricle and left ventricle also bulges towards the left ventricle side. So, when this bulges towards the left ventricle side, the effective cavity of the left ventricle is reduced. So, the receiving capacity of the left ventricle is effectively reduced. Moreover, the pumping effect of the right ventricle is also less. So, the blood which is coming to left ventricle is also reduced. The effective capacity of the left ventricle is also reduced, so that the cardiac output is effectively reduced. Okay, so this is the overall picture of acute pulmonary embolism. Coming again, so there is a clot in the pulmonary artery, so the pressure increases in this. That is one reason why the pressure increases, that's pulmonary artery hypertension. The other reason is this increases the thromboxane A2 and serotonin, which causes further vasoconstriction. Moreover, the hypoxia caused by this pulmonary embolism causes vasoconstriction again. So, a clot causes increase in pressure. The hypoxia causes vasoconstriction and increase in pressure. Serotonin and thromboxane A2 causes pulmonary vasoconstriction and increases in pressure. So, ultimately, there will be increased pulmonary artery pressure, right. So, when there is an increased pulmonary artery pressure, this pressure gets transfused into the right ventricle. So, right ventricle bulges, neurohumoral hormones get activated. So, myocarditis happens. So, this myocarditis is one reason where you can see hypotension even after treating your pulmonary embolism. Okay. So, the work of contraction, the right ventricle increases, whereas the blood supply decreases. So effectively you can get a right ventricular infarction also. Okay, meanwhile you can have some tricuspid regurgitation jets. So this is overall called as acute pulmonary embolism. So now you can understand that the hypotension is primarily caused by decrease in blood supply to the left ventricle and decreased receiving capacity of the left ventricle because the cavities itself is very much minimized. Okay, so this is overall the pathogenesis of how a pulmonary embolism affects your hemodynamics. So the RV dilatation happens, causing tricuspid valve insufficiency, right ventricle wall tension increases, neurohumoral activation happens, so myocardial inflammation occurs, so RV oxygen demand increases, intrapulmonary AV shunting can happen. Not only the intrapulmonary AV shunting, if in the heart here from the right atrium to the left atrium, if there is a patent foramen ovale, so the pressure which is getting transfused from the pulmonary artery to the right ventricle to the right atrium can go through this foramen ovale into the left atrium. Okay, so the venous blood from the venous blood which is oxygen deficient blood in the right atrium can mix with the left atrial blood. So there will be profound hypoxia which you will not be able to correct by just giving oxygen. Okay, so presence of patent foramen ovale is actually detrimental in a pulmonary embolism. So intrapulmonary AV shunting happens, RV ischemia and hypoxic injury occurs. So this leads to decreased RV contractility, decreased RV output, decreased LV preload, so decreased cardiac output. So effectively causing hypotension. Hypotension causes coronary perfusion, decreased coronary perfusion of right ventricle, and RVO2 delivery also decreases. So this all leads to obstructive shock and death. Okay, so this is the overall pathogenesis of how a pulmonary embolism can cause hypotension, hemodynamic instability, obstructive type of shock and death.